All right. So we have a submucosal tumor presumed to be a lipoma at the duodenum. For this lesion, the obvious solution and the easiest could be to endoloop and let it go.
Right.
All right. Another option would be to do a simple EMR. It's totally acceptable. Probably most people will do that. But
We're not most people.
okay. So we're going to do ESD. I cannot justify it from a scientific point of view 100%, but I have to recognize that there is a big advantage.
Yes.
So when you cut such lesion, you will encounter the vessels one by one during ESD. So in case of a major vessel that penetrates through the duodenal wall, we will identify it, use a coag-grasper, and coagulate it.
Right.
But if you do EMR, then you cut many vessels potentially at the same time, and you may be in an uncomfortable situation with readout.
Correct.
So the strategy is as follows. We will fill the lumen with normal saline, because this is very crucial for duodenal ESD. Then we will proceed with circumferential incision, place a clip and band, and then apply traction, and finally complete the resection. So let's do it.
All right.
Okay. So you have sound here in the room?
Yes, we have sound. Now we are hearing you, and
Perfect.
we have heard your strategy.
All right. We are at the junction of the first and second portion of the duodenum. This is the lesion. It's a little bit ulcerated at the tip. We have filled the lumen with normal saline. All right. And I have placed a few dots marking. It's not necessary, but I really like it in case I lose my orientation. Now, I have already inserted a clip with a rubber band. The plan is to place this complex of clip and rubber at the tip of the lesion to apply traction. Why? Because when we do that, first of all, we fix the specimen and we don't risk to lose it. Second, the cutting becomes more effective. So when we have traction in ESD, when you cut, you are more efficient and you cut more fibers, more submucosal fibers than in standard ESD. Do you agree?
I agree. Absolutely.
Complete. Okay, so let's go.
And the other reason, as you're mentioning about the hemostasis, is this lesion is already ulcerated and bleeding. So if you do an EMR, there's obviously a vessel that's at the bottom, and this is going to help us avoid that, where we're going to have controlled hemostasis. You were saying something?
Close, close, close. Fire. Yes. Okay. Next clip, please. Buscopan? Yes. Okay. We will have to administrate Buscopan now.
So in the other parts of the bowel, more so, I think in the bulb, it's a relatively fixed area. So ideally, peristalsis should not bother us because the bulb is not mobile. D2 will be mobile, antrum will be mobile. So bulb I like because it's not going to have a lot of movement. On the flip side, you don't want any complications. As Georgios just mentioned, if there is bleeding, if there is perforation, bulb is a very difficult area to manage because of the retroperitoneal location, surgically or through IR. So that's why doing an ESD is also beneficial, because we can have more of a controlled environment compared to an EMR.
Ah, look, we have a bleeding.
Yes. The other part we were talking about is also the intermittent gastric outlet obstruction. Patient is having some symptoms because, as you can see, this is a prolapsing lesion that's falling in and out. So this will also help treat that.
Okay, so I don't need to open it a lot, just a little bit.
Just a little bit.
Interestingly, we have a bleeding just by touching the lesion, so maybe ESD is not a bad idea
Not
for
at
that
all.
case.
I think this makes even more sense now.
And I suggest to inject adrenaline prior to start now. So when we have bleeding, it's best to use CO2. So underwater is not let's say,
Yeah.
It's not easy to deal with the bleeding during underwater dissection.
And gives poorer visualization. So it's better visualization with CO2 insufflation with bleeding.
Okay.
There you go. See right at the tip, there is a oozing vessel.
I need the clip. I just removed it to aspirate. Just give me the clip again to fix the
clip
tumor.
back.
Yes.
See right there, there is a vessel right at the tip, and we didn't even touch that vessel yet. So clearly, this is a symptomatic lesion.
So in these patients, 1 week prior to the procedure, either it is a gastric ESD or a duodenal ESD, I administrate high dose of PPI. So we ask them to take double dose of PPI 7 days before the procedure,
Right.
just to prepare the stomach or the duodenum.
And you can see here, the bleeding is not a lot. It's a little bit of an ooze. However, it looks a lot underwater.
Okay, close. All right, perfect. Okay, now we're going to fix it.
On the opposite wall, yeah.
I want just to apply some tension.
Right.
So, step back.
Yeah.
There, here, okay,
Nice.
here is nice. So, open slowly. Yes. Close. Perfect. Deploy. Yes, fire. All right. I step back. In duodenal ESD, supine position is very important in order to keep the water inside the lumen. Okay.
Look at that traction. That's
Okay.
beautiful. It's
Yes.
already
All right.
opened up so much better.
Now I need injection needle, please. I will refill the lumen with saline. Do you have, we have adrenaline, right? Yes, yes, okay, perfect. I will inject. So in my procedures, I usually inject at the beginning of the procedure 5 cc, 5 milliliters of my dilution, which is normal saline with adrenaline and blue. But then, after that, almost never, I don't use injection anymore. I use my flash knife. I think the biggest revolution in ESD that make it accessible to mortals like me and not Japanese is the water injection properties of the knife, the traction, and under saline technique. All these 3 key elements make this procedure accessible to us. Okay, please needle out.
Georgios.
Yes.
I think
Oui.
the traction was nice. Question: why do you use underwater?
Underwater, yes, good question. In
The
duodenum
traction
is
is
very
nice.
important.
Maybe you don't need underwater.
Stop. Okay, because when you work under saline in both duodenum and colon, where the wall is very thin, you have a very good detachment of the submucosal space from the muscle layer. The only reason to stop using under saline during these techniques, in my humble opinion, is when you have bleeding.
Bleeding, agreed.
Because the blood goes everywhere and you don't see.
Right.
In addition, the coagulation currents do not work well under saline.
But Georgios,
And we have a lot of
this I
bubbles.
understand. But as you are using traction, maybe underwater is no more necessary. So why you combine both?
Yes, because I have discovered that when you combine all techniques together, you go even faster. So I'm not among those who use either traction or under saline alone. I love to combine all techniques. So please needle out. My marking is far away. Okay, needle out. Here I'm safe.
I think underwater, the other part is just similar to what we do under EMR. Look at those vessels. I think this is why ESD is so much more elegant. Is again, the identification of the submucosal space when you insufflate, it actually goes away versus this gives us a very controlled environment and vision. As long as Georgios mentioned, there is no bleeding. Bleeding, everything is read out. But here, you can see underwater, it gives us a nice controlled environment for dissection plane identification as well. Oh, that's
So,
beautiful.
I will move from left to right. I think it's the safest movement I can do right now. I just rotate the shaft of my endoscope. I don't move the wheels anymore. Here we see some vessels I will inject. I pull back my knife and I may use coagulation in this area. Yes?
So for everybody else, we're using the Vio 3 machine for the dissection. So Georgios, you're using the endocut eye, right? So once you do your mucosal incision, what do you think about precise sect
Yes.
for submucosal dissection?
It's a good current, but I prefer spray.
Spray, okay. Even for dissection?
Yes.
So I've used personally come to love the precise sect for the submucosal dissection because I feel like it has the cut coax. I don't use the endocut anymore. I use the precise sect because it gives, it's a slightly more charry. It's not as clean as what Georgios demonstrating here. But there's definitely less bleeding.
So the reason why I use endocut is because it's the only bubbleless current.
Yes.
And nowadays there is.
Do you think?
Yes, this is the lipoma.
Right there, above is the lipoma, and I think we're right below the lipoma.
Yes.
We're getting it intact with the capsule.
This will be an R0 resection.
R0 resection.
Ah, okay.
Lipoma R0 resection.
So now we have to be careful.
Yes.
Because at this point, when I will cut the mucosa, my knife will drop suddenly over the posterior wall. So that's important. For that reason, it's important to do tapping and not press continuously the pedal.
Right.
Because you will injure the wall. Now, at this point, for safety reasons, I will change my strategy. I will put my knife from right
to left.
To left.
The other thing, what do you think about using the insulated tip knife,
yes,
the IT2?
Very good. This is excellent. This is excellent.
For the back part,
yes,
and then hook and pull instead of push.
And you know something? We will do that. Please prepare the IT knife nano. I will hook the tissue here.
And the IT Nano is an insulated ceramic tip at the back end, and it also has the grabbing property. So as Georgios is dissecting, you don't have to worry about injuring the back wall.
Yes, yes, please. So this is an excellent indication for that knife. You see, we have vessels indeed.
Yes.
So I use spray.
Spray coil.
I target. So imagine doing EMR in this case.
This would have been a bloodbath. Yep. I think you're on forced.
We are on forced. Okay. Let's switch to IT knife nano.
Okay.
This is the perfect indication for that knife. Normally we should finish in 2 minutes if we do everything correctly. Now, our traction is important also because once I cut,
it's going to flop.
It's going to flop, and we risk to miss the specimen.
Yes.
At the third portion of the duodenum.
Right. I think it's going to hold it in place, so that's important. The other thing to be careful where you clip, in the second portion is not make sure it's not grabbing the papilla as you're going around the sleeve.
Yes. Please fill with water. It's half finished. Open the knife, please.
See, this the nice thing about the IT Nano here is it grabs the tissue from the back, but you don't have to worry about injuring the back wall because of the insulated ceramic tip on the other side. Beautiful. Hook, pull, bring it towards you. Oh, look at that.
Ah, now it's nice.
Now it's nice.
Better with
It's
air,
literally a 30-second and we're done.
huh? Georgios,
towards you
when
and
you
you're
have
done.
when you are
There.
under air, it's better.
Ta-da!
Or
Okay.
you see better.
All right, done.
Congratulations.
It was over treatment, okay? We did mostly for, let's say,
But bleeding prevention, I think this would have bled. I honestly don't think it's overkill. I think doing this ESD gave us a much more controlled environment compared to blindly putting a EMR or a endo loop.
once you have understood the principles of ESD and you have precision in your movements, it's safe to do it.
Exactly.
But it's not the way you start doing ESD, okay?
Correct.
So please, give me the coag grasper, because as you see, we have some big vessels here.
grasper.
Now I have to empty the lumen from water, because soft coagulation does not work well under saline.
Yep, under saline. Yep.
Soft. So the standard setting is 4.0 or 5.0, about 8 bar.
5.0.
5.0 is okay.
Yeah.
And I will grasp the vessel, pull back, and apply coagulation for, let's say, about 2 seconds. We have to be aware of potential thermal injury and late perforation. So this is not the coag grasper for stomach. This is the thinnest version for the colon. I always use this coag grasper.
For duodenum also.
Yes. So please close. Now I don't press the pedal. I pull back. Pull back. Stop. Open. Grasp. Pull back. Open. Pull back. Okay. Open. Let's wash.
Let's wash and see, yeah. Right there.
With the coag grasper? No. Yes. Yes. I never used forced with coag grasper. The advantage of soft coagulation is that although we don't see it, it goes deep into the wall. So it's a current that goes, it is transmitted at the deepest part of the wall.
Georgios?
Close. Yes.
Yes. Why not just using a hot biopsy, which is less
Hot
expensive?
biopsy. Hot biopsy is it's a much more it's
I think the hot biopsy, the difference is it has the cup, so it's to do with the thermal spread. With the coag grasper, the jaws are flat, so when you oppose it, you're crushing the vessel in the middle. A hot biopsy forceps will stay hollow, so the current will arch inside and may not do it completely. Now, if it's a small vessel, hot biopsy will work okay, but if it's a big vessel, then you want the coag grasper. Otherwise, with a hot biopsy, it will pop the vessel and not coagulate the vessel.
I don't agree.
No?
I agree, but
Okay.
if you
So
use a hot
for
biopsy,
tiny-
it will work perfectly.
For tiny vessels, coag grasper is more precise. So sometimes in the rectum, I fail to control the bleeding, major bleeding, with a coag
okay.
grasper, and at that point I use a biggest forceps.
Hot biopsy.
Now, to answer your question, here I want to be more precise and have minimum area of thermal injury.
Right.
That's the reason why I prefer coag grasper. Open, close, I pull back,
A little
no.
bit to the left,
Open,
maybe.
close. Let's wash. We have to identify the vessel.
Yeah.
I will go close, try to identify the artery on the left side here. Open, close. Okay. So, to be honest with you, in the duodenum, I don't insist a lot to coagulate all vessels because I have experienced perforation during coagulation with the coag grasper. Here, the wall is a little bit thicker than in the second portion of the duodenum. I will apply one more time, and then I will stop and place clips. It's not like the stomach or the colon. Okay, stop. Okay.
Yeah, I think we
we
got that.
had planned to use X-Tack, but I think it's
Overkill.
over treatment. I mean,
Regular endo clips is...
We will put some 3-4 clips. So there is a principle for duodenal resections, polypectomies, ESD. We always close the defect, always.
That's beautiful.
You know,
Look at that lesion.
Prior to close the defect, let's remove it because the clips will
Get in the way.
Now, how are we going to remove the endoloop? Professor Poisson.
I think you should
you there?
take the band, maybe.
How do you remove the band?
No, or you take the clip with a small snare.
You take the tip, yes, but this will provoke injury to the wall.
Yes.
Okay, but
We are at
does
the
not
duodenum.
matter too much. No, does it matter?
Sorry?
But you have a small injury to the duct. You want to what? You want to open the clip?
I want to retrieve my specimen. What do you suggest? Do you suggest to take a snare and pull the clip? Right, okay. If I was
Yes.
at the stomach, if I were at the stomach, I would do it. But there is, I use another technique. I use this device, open it.
Endo scissor. Yep.
This is an endoloop cutter. Close it.
We'll see.
So I think
I never
this is
seen
the-
this before. It's
Yes,
new for
I
me.
use it
So
this
you
for
are my
the-
teacher.
for the
Huh?
la- I use it for the last 7 years. It works very well for this type of rubber bands.
Yes.
The only problem is that you have to be a little bit lucky because
where
the
it opens.
orientation has to be convenient. And now, open it. Okay, so we're not lucky.
Opens down.
Let's try. Ah, yes, I am able to rotate it. So open, close, open. Okay, so I will rotate it. Don't rotate it. I will do it.
Okay.
Ah, not this way. Never mind. Okay.
Yep.
So I will step back and try to identify the rubber band. Yes. Here. No, it's okay, it's
No,
okay.
It's okay.
I will just have here. Close. Open. All right.
So there's another device called endo scissors that also works in a similar manner, especially for removing
Close.
right
Yes.
there. And then,
Yes. Now I pull. I just pull, and that's it.
see,
Some-
it cuts it.
It's cut.
And
But
now
sometimes that's not enough. Wait. Sometimes that's not enough.
Because it only removed from one side. So
I
if
have.
you just pull, it'll come out.
Yes, we have to mobilize it a little bit.
Very simple,
We don't
Georgios.
lose it. Sorry?
It looks very simple.
I lose that.
I'm joking
It's
a
not
little.
simple.
I see what you
Okay.
want to do, huh? But this is okay.
Okay,
It's
it's okay.
out.
It's out.
It's out.
Yeah.
Now, please give me a snare.
Great. Okay.
Retrieval
Snare.
net.
A snare. No, snare.
Okay.
A cold snare or a snare. I will.
snare.
Now, I will grasp my clip with a snare and pull back and retrieve the specimen.
But which clips?
hold the
Which clip?
specimen.
Georgios,
The
which
specimen
clip
clip.
you want
Yes.
to take?
Which clip?
Yes, you have two clips here.
I will grasp the clip that it is located over the lesion.
Ah, yes, of course.
We don't have a snare here in the room because we do only ESD. Go to the other room, please.
And the other modality is also to put a retrieval net, like put a big retrieval net and then take it out. One thing, as you said, with the snare, we can hold on to the clip, but you worry, will the clip come off as you're pulling? Especially for a big specimen, it can get caught at the GE junction while you're trying to pull it, or at the upper esophageal sphincter, and
Indeed.
it breaks the specimen. But if we have it in a retrieval net,
Yes.
then it'll hold on to the specimen and give you more traction.
In the case we had at the morning with the stair, the gist was attached at the clip, but when I pulled back the line, the tumor was detached at the esophagus.
Right. So I think just milks it out at the GE junction.
It's a very elegant thing to do with the envelope cutter, but what's the price of this scissor?
So it's reusable. You buy it once. Open. close. Oh no, sorry. I have to go underneath.
Yeah, I think that would have worked. Okay, let me hold you down, Georgia. There. No.
No. Open. Ah, yes. Close, 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 close. Yes.
Yes.
Now we pull back. Okay, be careful because here we have to. Ah, thank you. Oops.
See, this is what I said.
This is what you
At the
said.
GE junction, it's gonna let go. So it's okay. Take the clip out at least. So
Next time, applause after the retrieval. Okay.
hold the applause.
Open, 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 open. Yeah, let's hear. What are we going to take? A basket? Roughnet.
Roughnet, yeah.
Roughnet, please.
You have a big Rothnet.
Okay. Find the roughnet, and until we have the roughnet, let's close the
Close the
defect.
clip. Yeah. Because your lesion
Georgios,
is now.
you did very well. Just I wanted to joke a little because you are so good. Nevertheless, the cutting device you use to cut the bone is single use or it's reusable device?
Endoloop cutter? It's
Yes,
It's
Single use.
reusable.
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 Okay.
No, Rothnet.
So I will place the first clip beyond the defect, open and rotate. Yes.
Perfect. Yep,
So-
right there.
All right. So we will create a fold and place this just after here.
Yeah.
Close. Close. Yes. Fire.
Yep.
Yes. Okay.
Mai desfăm două cel puțin. Unul la pe masă.
Stop the bleeding also. It's oozing again a little bit.
Another question, Georgios. I think this technique that you use, ESD, of course, in this case, it was perfect. It's also an indication when you have a large polyp in the colon with a large stalk, with a large peduncular, okay?
Yes. Yes.
Because
yes,
it's
yes,
more precise than snaring, okay? I think probably
Uh,
it's an excellent indication too.
Yes.
I never
Yes,
perform
because
now a resection with a snare of a large polyp.
And
I
for
prefer to
young
use
doctors,
ESD.
I think big polyps are a good occasion to start ESD.
Yes.
So I will push my clip, pull up. Don't hurt. All right. Stay there. All right. There. Yes. Close. Go. Fire. Next. What clips?
Any net? Any net? No net.
Whatever. Give me snare. I will use the snare. I can maybe I will aspirate it. It will probably be trapped inside my cup. Okay, open. Oops, sorry. Oh, close.
Yeah. One more.
Okay. Yes. Stay there. Close. Next. Fire. Go. Next.
One more, maybe.
One
that's it.
more. Yes. Open. Yes. Stable.
Georgios, you like clips, huh? And they like
Yes,
you, huh?
and I always my nurse says, you always, doctor, place more clips than needed.
That's okay.
Close. Fire. I will place one more. One last one.
One more?
Looks good,
Oh.
man.
I know.
wants-
I have insecurity issues. I see.
I'm your confidence.
I see a doctor for that. Also, I check always whether there are any gaps between the clips.
Yes.
I'll place one final clip and we're done. Open.
And an endo loop.
You rotate. Yes. There. Ah. Okay. Open.
Georgios,
Yes.
may we change to room 2?
Yes.
Thank you.
Yeah.
Thank you,
Bye-bye.
Georgios.
Thanks a lot. Bye bye.
Bravo, bravo, Georgios, bravo.